All right, I am back. Can everybody hear me?
Yes, sir.
The others respond.
Sir.
Yes, sir.
Ms. Jackson, are you present?
Yes, sir. I hear you.
Not you, Rowan. Ms. Jackson. I need a response from Ms. Jackson. Ms. Jackson, are you present? All right, give me 2 minutes. All right, guys. Just before I get back into the subject area, I want to just point out something that I've observed and what I'll be doing going forward. So I don't know if you guys are aware of this, but when I log in on my end, I can see your connection. So I know if you have a bad connection or a good connection, right? So if I am speaking to you and your connection has not dropped, it means that you're not at your computer. And if I don't get a response when I'm speaking to you and you're not at your computer, I'm going to remove you from the session. Everybody understand that?
Yes, sir.
Yes, sir.
All right. So let me repeat. On my end, I can see your connection. So I know when your connection is bad. I know when you're going to be removed from the group because of connection issues. If I am communicating with you and your connection has not dropped and I'm not getting a response, it means you're not paying attention and you're not at your computer. So I'm going to do a roll call again, and I expect everybody to respond. So, Miss Johnson, are you able to hear me?
Yes, sir.
Miss Nesbitt,
Yes, sir.
Mr. Jennings,
Yes, sir. Yeah.
Right.
Present, sir.
Miss Jackson. Miss Jackson, you have too much noise in your background. Miss Jackson, are you able to hear me? If something is wrong with your mic, type in the chat.
I'm here, sir. The mic wasn't coming on.
If you're not able to use your mic, type in the chat. All right. I will now continue. So we were on the primary assessment for the pediatric patient. Breathing. Use a local feel technique. Place both hands on the patient's chest to feel for rise and fall of the chest wall. Belly breathing in infants is considered adequate. Bradypnea is an ominous sign and indicates impending respiratory arrest. All right, now circulation. Determine if the patient has a pulse, is bleeding, or in shock. In infants, palpate the brachial or femoral pulse, right? So very important point. In infants, palpate the brachial or femoral pulse. In children older than 1 year, palpate the carotid pulse. Strong central pulses usually indicate that the child is not hypotensive. All right, now weak absent peripheral pulses indicate decreased perfusion. Tachycardia may be an early sign of hypoxia. Interpret pulse within the context of overall history and the pediatric assessment triangle and your primary assessment. Evaluate trend of increasing or decreasing pulse rate. Feel skin for temperature and moisture. Estimate the cap refill time. For disability, as I said earlier, you're really looking at the level of consciousness at this point. So use the AVPU scale or pediatric GS, check pupil response, look for symmetric movement of the extremities. Pain is present with most types of injuries. Assessment of pain must consider developmental age of the patient. For exposure, hands-on ABC is required that the caregiver remove some of the patient's clothing for observation. Avoid heat loss by covering the patient as soon as possible. More prone to hypothermic events should be kept warm during transport. All right, now after the ABCDE, at this stage you can now make your transport decision. Determine whether rapid transport to the hospital is indicated. Rapid transport is indicated if there is a significant MOI, history compatible with illness, physical abnormalities noted, potentially serious anatomic abnormality exists, significant pain is present, the patient has an abnormal level of consciousness. Also consider the type of clinical problem, benefits of ALS treatment in the field, local EMS protocol, your comfort level, transport time to the hospital. If patient's condition is urgent, initiate immediate transport to the closest appropriate facility. All right, now less than 40 pound, transport in car seat. So with a car seat, you can read this on your own. Not going to go through that right now. So that part of it, I won't go through. Now, after you have completed the A, B, C, D, E's of your primary assessment, the next phase of your assessment is the history taking. Approach to history depends on the age of the patient, right? So history information for an infant, toddler, or preschool age child, you'll rely more on caregiver or parent, right? Adolescent information is obtained directly from the patient, questioning parents or child about immediate illness or injury should be based on the child's chief complaint. All right, now questions to ask based on the chief complaint, right? NOI or MOI. You can ask questions centered around that. The length of time the child has been sick or injured. Key events leading up to illnesses and injuries. Whether fever is present. This is a key one. Whether fever is present, right? And if fever is present, you have to start thinking about infections. And when pediatric patients start to develop infections, they're going to get dehydrated, right? Now, effects of illness or injury on behavior, the patient's activity level, recent eating, drinking, or urine output, right? Questions centered around changes in bowel or bladder habits, the presence of vomiting, diarrhea, and abdominal pain, whether there are any rashes present, obtain name and phone number of caregiver if they are not able to come to the hospital with you. You will also sample history, so same as adult, questions based on age and developmental stage. Obtain OPQRST, same for children and adults. Questions are based on age and developmental stage. In your secondary assessment, right, you're going to be doing a physical examination. It can be detailed, it can be focused, right? So secondary assessment of the entire body should be used when the patient is unresponsive or has a significant MOI and using a decap BTLS pneumonic. Focus assessment should be performed on patients without life threats. Focus on areas of the body affected by injury or illness, as well as on the chief complaint, MOI or NOI, and the findings of the primary assessment. All right, now physical examination. Infants, toddlers, and preschool age children, we learned this earlier, should be assessed starting at the feet and then you go to the head. School age and above, you assess from the head to the toe. So at the head, you look for bruising, swelling, hematomas, assess the fontanelles in infants. Is it sunken? Is it bulging out, right? So if it's sunken, then that's dehydration. If it's bulging, that's overhydration. All right, now nose, nasal congestion and mucus can cause respiratory distress in a very young pediatric patient. Why? They rely more on the nose for breathing, right? Gentle bulb or catheter suction may bring relief. For the ears, drainage from ears indicates skull fracture. Look for battle sign, which may indicate a skull fracture. The presence of pus may indicate an infection. For the mouth, look for active bleeding and loose teeth. Note the smell on the breath. For the neck, examine the trachea or tracheal area for swelling or bruising. Note if the patient cannot move the neck and has a high fever. Very important sign. Can't move them, have a high fever. That's associated with meningitis. For the chest, examine for penetrating trauma, lacerations, bruises, or rashes. Feel clavicles and every rib for tenderness and or deformity. For the back, inspect the back for lacerations, penetrating injuries, bruises, or rashes. For the abdomen, Inspect for distension, gently palpate and watch for guarding or tensing of the muscles, no tenderness or masses. Look for seatbelt abrasions or bruising. For the extremities, compare left to right, look for symmetry, right? Compare both sides for color, warmth, size of joint, swelling, and tenderness. Put each joint through a full range of motion while watching the patient's eyes for signs of pain. For the vital signs, very important slide. Some guidelines equipment used to assess adult circulatory status have limitations in a pediatric population. Normal heart rates vary with age in a pediatric patient. The younger they are, the faster the heart will beat. For blood pressure, it is usually not assessed in patients younger than 3 years, so we don't really rely too heavily on a blood pressure if they are below 3 years of age. Assessment of the skin is better indication of the pediatric patient's circulatory status. When equipment is used, it is important to use appropriately sized equipment. Use a cuff that covers 2/3 of the pediatric patient's upper arm. Right? Use this formula to determine blood pressure for children ages 1 to 10. So it's 70 plus 2 times the child's age in years. That will give us a systolic blood pressure. Respiratory rates may be difficult to interpret. Count respirations for at least 30 seconds and double that number. If infants and those younger than 3 years, infants and those younger than 3 years evaluate respirations by assessing the rise and fall of the abdomen. Very important, right? So younger than 3 years, they rely more on the diaphragm to breathe because their chest muscles are not well developed. So you tend to see more abdominal movement than chest movement, right? For that age group. Assess the pulse rate by counting at least 1 minute, noting the quality and regularity. Normal pediatric vital signs vary by age. Assess respiration, then pulse, then blood pressure. Evaluate pupils using a small pen light. Compare size of pupils. Pulse oximeter is a valuable tool for patients with respiratory issues. And the final phase of the patient assessment is the reassessment. So reassess the pediatric patient's condition as necessary. Stable every 15, unstable every 5 minutes. Continually monitor respiratory effort, skin color, and condition, right? Pay attention to the level of consciousness and how they are interacting with their environment and the caregiver or parent. You will consider your intervention. Parents or caregivers may be able to assist, able to calm and reassure the child, often well versed on their child's medical condition. They can assist with oxygen administration and nebulization of the patient. Communication and documentation is also done in our reassessment, right? All right, now let's look at specific emergencies and how we will approach managing these emergencies. So starting with respiratory emergencies and management. Respiratory problems are the leading cause of cardiopulmonary arrest in a pediatric population. So especially the smaller pediatric population, because of the differences in their airway, put them at a high risk for respiratory issues, and this can quickly lead to cardiac arrest in that age group. Failure to recognize and treat will lead to death. Patient must work harder to breathe and will eventually go into respiratory failure. And a key sign of respiratory failure in your adult or pediatric patient is poor chest rise, right? In the early stages, you may note changes in behavior such as combativeness, restlessness, and anxiety. Now, signs and symptoms that something is definitely wrong with breathing: nasal flaring, abnormal breath sounds, use of accessory muscles, and tripod positioning. As the pediatric patient progresses to possibly respiratory failure, and again, the key thing that we're looking for to determine if our patient is going into failure is changes in the level of consciousness and poor chest rise. Efforts to breathe decreases, chest rises less with inspiration. The body has used up all available energy stores and cannot continue to support extra work of breathing, right? And once those muscles get tired, they just stop breathing. Without care, cyanosis may develop and death may quickly follow. All right, now changes in behavior and eventually altered level of consciousness. Again, one of the key signs that your patient is going to fail on you is changes in the level of consciousness and whether or not you can see visible chest rise, right? So level of consciousness is going to change and the chest rise will be reduced. Changes in behavior and eventually altered level of consciousness. Patient may experience periods of apnea, heart muscle becomes hypoxic. This leads to bradycardia. When you have a pediatric patient that's bradycardic, they are close to cardiac arrest, right? And remember, if it's an infant and it's below, well, infant or newborn, and it's below 60, we need to start chest compressions. As the patient progresses to possible respiratory failure does not always indicate airway obstruction. Condition can progress from respiratory distress to failure at any time, right? Reassess frequently. A child or infant needs supplemental oxygen. For infants and children in possible respiratory failure, assist ventilations with a BVM 100% oxygen. Allow patient to remain in a comfortable position. That's for supplemental, not for BVM. When it's BVM, patients will be on a flat surface. Elevate the shoulders as needed based on their size. All right, now airway obstruction. Children can obstruct airway with an object they can fit into their mouth. In cases of trauma, teeth may have been dislodged in the airway. So blood, vomitus, or other secretions can cause severe airway obstruction. Infections can cause obstruction, right? So infection should be considered if the patient has congestion, fever, they are drooling, or they have cold-like symptoms. Croup is an infection in the ear below the level of the vocal cord. So croup is actually laryngeal tracheal bronchitis, right? It's caused from a virus that affects the structures in that area. Epiglottitis is an infection of the soft tissues above the level of the vocal cords. It's more linked to a bacterial issue, so they tend to have a higher fever than the croup patient. Alright, now obstruction by foreign objects may involve upper or lower. Obstruction may be partial or complete. If it's a partial obstruction, you need to answer some questions. Does the patient have a partial obstruction, good air exchange, or poor air exchange? If it is a partial obstruction with poor air exchange, you treat it as a complete obstruction. So signs and symptoms associated with partial upper airway obstruction include decreased breath sounds and stridor. Stridor is a high-pitched whistling type wheezing sound that is linked to an upper ear issue. You can hear it with Croup actually, right? So you can hear stridor with a Croup patient. Not all will have it, but you can definitely hear it with a Croup patient. Infants or children with a complete airway obstruction will not make any sound, excuse me, have no breath sounds, and become rapidly cyanotic. Signs and symptoms of lower airway obstruction include wheezing and crackles, and wheezing indicates bronchoconstriction. Crackles indicate fluid in the alveoli. Both are bad. Now, best way to auscultate breath sounds in pediatric patient is to listen to both sides of the chest at the armpit level. Very important point, right? So the best way to auscultate breath sounds in your pediatric patient is mid-axillary, right? Mid-axillary. In adults, it is in your pediatric patient, mid-axillary. Now, immediately begin treatment of a airway obstruction. Encourage coughing to clear airway when the patient is conscious and they can cough forcefully. If this does not remove the object, do not intervene except to provide oxygen. Allow the patient to remain in whatever position is most comfortable. If you see signs of severe airway obstruction, attempt to clear the airway immediately, right? So if there's an ineffective cough, no sound, inability to speak or cry, increasing respiratory difficulty with stridor, cyanosis, loss of consciousness, then we need to move, and we need to move quickly. If an infant is conscious with a complete airway obstruction, you will perform up to 5 back blows followed by chest thrusts. This is CPR stuff. Position the infant face down on your forearm, slap the back forcefully 5 times between the shoulder blades with the palm of the hand. If the airway does not clear, flip the child onto his or her back and perform 5 chest thrusts in the same manner you would perform CPR. Repeat the process until the obstruction clears or until the infant becomes unconscious. If the child is conscious with a complete airway obstruction, perform abdominal thrusts. Right? Continue until the obstruction is relieved or until the child loses consciousness. Now, once they lose consciousness, you will approach the child. You will be doing CPR. The only difference is every time you go to give breath, you will check to see if there is something in the mouth, and if you can physically reach it, you reach it and remove it, right? That's BLS stuff. All right, now airway obstruction. Use head tilt, chin lift, and finger sweep to remove a visible foreign body in an unconscious pediatric patient. Use chest compression to relieve a severe airway obstruction in an unconscious pediatric patient, right? And when we perform these maneuvers, it's either it's going to come back up or it's going to go down. And usually because of how the airway anatomy is designed, it tends to end up in the right stem of the bronchi. And if it's in the right stem, they can breathe on the left. So that's not too bad. Now, asthma. A condition in which the bronchioles become inflamed, swell, and produce excessive mucus, right? Leading to difficulty breathing. This is a true emergency, and it requires early treatment, especially in your pediatric population, right? I've seen so many pediatric patients die because of asthma, right? You can't take this lightly in the pediatric patients. So remember, there are 3 things that occur. The airway becomes constricted because of the inflammation. It swells as well. So there is edema, there is constriction, and there is mucus building up in the ear passage. It's a true emergency. It requires prompt treatment. 10% of US children are affected. Common causes of asthma attack include upper respiratory tract infection, exercise, exposure to coal, air or smoke, and emotional stress. I believe the patient, yeah, that's for later. Now, signs and symptoms. Wheezing, characteristically heard on exhalation. In some cases, the airway is completely blocked and there is no movement heard. This is not good, right? So if we can't hear any ear movement, they are not in good shape. Cyanosis and respiratory arrest may quickly develop. Tripod position allows for easier breathing. All right, the treatment, allow the patient to assume a position of comfort. Supplemental O2, the patient would definitely benefit from a bronchodilator via meter-dose inhaler with a spacer mask device, and the medication of choice for that is Ventolin. That's what your protocol will allow. Depending on whether you work in you're a partner for an ALS system, then that can be Ventolin and Atrovent nebulized. If assisting ventilation, use slow, gentle breaths. Resist temptation to squeeze the bag hard, right? Try not to ventilate the pediatric patient forcefully. You can rupture the alveoli and create a pneumothorax. A prolonged asthma attack may progress to status asthmaticus. So this is when the treatment, the traditional treatment does not work, right? They are not responding to traditional treatment. A true emergency. Administer oxygen and provide rapid transport. The patient becomes exhausted and stops struggling to breathe. You have to manage the upper and lower air, right? Manage the airway aggressively. Administer oxygen, transport promptly, consider ALS support. Now, pneumonia. This is a leading cause of death in children, right? Infection of the lungs. Pneumonia is a general term that refers to an infection to the lungs. It is often considered a secondary infection. So they got something initially, they are recovering, might not be in an environment that is very clean. They pick up a bacteria and in that area, and it develops into an infection. Can also occur from chemical ingestion, right? Diseases causing immunodeficiency in children puts them at a higher risk for pneumonia. Incidence is greatest during fall and winter months. Presentation in pediatric patients, unusual rapid breathing, sometimes with grunting, which will suggest there might be an upper airway problem, wheezing, which suggests a lower airway issue. Nasal flaring, tachypnea, they might be presenting with hypothermia or a fever. There is unilateral diminished breath sounds or crackles over the infected lung segment, right? So it starts in one segment. If it doesn't get better, then the bacteria can enter the blood and become systemic, and then they end up in septic shock. Pediatric patient treatment, primary treatment will be supportive. Monitor the upper airway, monitor breathing status. Administer supplemental oxygen. Because it is an infection, they will benefit greatly from humidified oxygen, because when they have infection, they're going to get dehydrated. If the mucous membranes are too dehydrated, it might not be able to absorb the oxygen very well. So they benefit from humidified oxygen. If the child is wheezing, they're going to need a bronchodilator The bronchodilator of choice is Ventolin, right? And it would be half the dose that you give an adult, as long as your protocol allows that. Diagnosis of pneumonia must be confirmed in the hospital setting. All right, now croup. This is an infection of the airway below the level of the vocal cords, usually caused by a virus, right? Typically seen in children between six months and 3 years, easily passed between children. Because it's a virus, it's associated with a low grade fever. It affects the larynx, the trachea, and the bronchi, sorry. Within some materials say between 3 to 5 days, they will start to show some of the signs and symptoms, right? Now, one of the issue is because of the inflammation that is taking place around the larynx and the trachea and the bronchi, it makes it very difficult for them to remove air, and they develop a hallmark sign. So stridor is going to have a seal bar cough as well. All right, now treatment. Avoid manipulating their airway, right? It's an infection. With infection, they get dehydration, so they will benefit from humidified oxygen. They will also, for bronchodilators, no. Right? So you can't give these patients Ventolin, because Ventolin has similar effects as epinephrine, right? It has sympathomimetic effects, so it can actually cause the mucous membranes to dry out. All right, now epiglottitis. This is a bacterial infection of the soft tissues in the area above the vocal cords. Incidence decreased since the development of vaccines. Epiglottitis. Sorry. Patients with epiglottitis, the epiglottis can swell to 2 or 3 times the normal size. Children look ill, right? They're gonna keep the airway open. They are in the tripod position. They drool a lot, right? They have a high fever. Avoid manipulating the ear passage, right? And just like the croup patient, they will benefit from humidified oxygen. All right, now bronchiolitis. It's a specific viral illness of newborns and toddlers. It's often caused by the respiratory syncytial virus, RSV. Causes inflammation of the bronchioles. RSV is highly contagious, and it spreads through coughing and sneezing, right? And the virus can survive on surfaces. The virus tends to spread rapidly through schools and child care centers. That's an important point to note, because we are thinking about sending back our kids to school with COVID-19 cases going up in the country. Kids are very good at spreading viruses, right? Extremely good at that. Now, bronchiolitis, more common in premature infants and results in copious secretions. Occur during the first 2 years of life, more common in males, right? Most widespread in the winter and early spring. Bronchioles become inflamed, swell, and fill with pus. And really, bronchiolitis is like asthma with fever. That's really what it is for that age group. It's like asthma with a fever, right? They're at risk for significant airway compromise, so you have to be vigilant in observing for that. Look for signs of dehydration, shortness of breath, and fever. They will benefit from humidified oxygen. Treatment: use a calm demeanor when approaching. Allow the patient to remain in position of comfort. Treat airway and breathing problems. Humidified oxygen is helpful. Consider EMS. All right, then you have pertussis, which is also called whooping cough or the 100-day cough. It is caused by a bacteria called Bordetella pertussis, right? It is less common in the United States. The signs and symptoms: it starts off with a cold, right? And eventually they develop a terrible cough, right? They have coughing fit to the point that they have to take a deep breath after the coughing episode. It is contagious, right? It is contagious. So signs and symptoms: coughing, sneezing, and runny nose. Coughing becomes more severe with distinctive whoop sound during inspiration. In their infant population, it can lead to pneumonia, can lead to respiratory failure. Again, one of the key things that you look for in respiratory failure: changes in level of consciousness, poor chest rise. To treat pediatric patients, keep the airway patent and transport. Pertussis is contagious, so follow standard precautions including wearing a mask and eye protection. All right, now your airway adjuncts. Devices that help to maintain the airway or assist in providing artificial ventilation. You have your oropharyngeal airway, you have your nasopharyngeal airway, right? Oropharyngeal airways are indicated for unresponsive patients, no gag reflex with a ventilation issue. Nasopharyngeal airways are indicated for your semi-responsive patient with a gag reflex, patient with a gag reflex, semi-responsive, and poor ventilation, right? So for the oropharyngeal airway, keep the tongue from blocking the airway and make suctioning the patient easier. Should be used for pediatric patients who are unconscious and in respiratory failure or respiratory arrest. Should not be used in conscious patients or those who have a gag reflex or who may have ingested a caustic or petroleum-based product. And when inserting the OPA in your pediatric population, we have to use a tongue depressor, right? So you have the 90-degree rotation or you have straight insertion, but you must use a tongue depressor. All right, now nasopharyngeal airway, usually well tolerated, used for semi-responsive pediatric patients, used in association with possible respiratory failure, right? So patient is semi-responsive with signs of poor chest rise. That's respiratory failure. Rarely used in infants younger than 1 year. Should not be used if there is nasal obstruction or head trauma, right? And in EMS, we tend to not use NPAs in trauma patients once they are critical. All right, now nasopharyngeal airway potential problems may become obstructed by mucus, blood, vomitus, or soft tissues of the pharynx. May stimulate the vagus nerve. This is important. May stimulate the vagus nerve. The vagus nerve is what controls the heart rate. So that's a nerve that can slow down the heart, right? If it is overstimulated, it can slow down the heart significantly. In a pediatric patient, this is dangerous. Why? Especially in the young. Because below 60 beats per minute, if the pulse goes below 60, it means that their cardiac output is significantly impaired, right? And this will lead to shock and cardiovascular system collapse, right? So may stimulate the vagus nerve and slow the heart rate or enter the esophagus, causing gastric distension. May cause a spasm of the larynx and result in vomiting if inserted into responsive patient. Should not be used when pediatric patients have facial trauma because the airway may tear soft tissues and cause bleeding into the ear passage. All right, now oxygen delivery devices. Several options for pediatric patients. You have blow-by, that's for you're very young, very, very young. Blow-by at 6 liters provides more than 21% oxygen concentration. Nasal cannula at 1 to 6 liters per minute provides 24 to 44% oxygen. Non-rebreather, which is a high-flow device, provides 10 to 15 liters per minute. That can give you up to 95% oxygen concentration. For your BVM, it's 10 to 15 liters per minute. Based on the seal that you're using, you can get up to 100% oxygenation. Non-rebreathing mask, nasal cannula, or simple face mask is indicated for a pediatric patient who have adequate respirations or tidal volume, but they are showing signs of difficulty breathing. A BVM is used for those with respirations less than 12 breaths per minute or more than 60 with alterations in their level of consciousness and poor chest rise. Blow-by method is less effective than face mask or nasal cannula for oxygen delivery. It does not provide high oxygen concentration. Administration: place tubing through hole in the bottom of a cup, connect tube to oxygen source at 6 liters per minute, hold cup 1 to 2 inches away from the nose and for the nasal cannula, some patients prefer nasal cannula, some find it uncomfortable. Applying a nasal cannula, choose the appropriate sized nasal cannula, connect tubing to an oxygen source at 1 to 6 liters per minute. In the EMS, we try not to go past 3 or 4 liters. We have to go above that, might as well give the patient high flow oxygen. For the non-rebreathing mask, it delivers up to 90% oxygen, allows the patient to exhale all carbon dioxide without rebreathing it. Applying a non-rebreather mask, select the appropriate size mask, connect tubing oxygen source at 10, 12, or 15 liters per minute. All right. For the bag valve mask, indicated in patients with too fast or too slow respirations, who are unresponsive or who do not respond to painful stimuli. Assisting ventilations with a BVM, you have to select the appropriate size equipment, maintain good seal with the mask on the face, and the best technique, well, it's easy with a pediatric patient. Ventilate at the appropriate rate and volume using a slow, gentle squeeze. Two-person BVM ventilation, similar to one-person BVM ventilation, except one rescuer holds the mask to the face and maintains head position. Usually more effective in maintaining a tight seal, right? So that's the ideal method for using the BVM two-person, right? But I don't want to say it's easy for pediatric because it depends. So that's your go-to if you have available personnel. If not, then and you know that your BVM technique is not that great, work with a pocket mask. All right, now in cardiopulmonary arrest, cardiac arrest is in a pediatric patient is associated with respiratory failure and then respiratory arrest. Children are affected differently by decreasing oxygen concentration. Adults become hypoxic and the heart develops dysrhythmia that leads to sudden cardiac death. Children become hypoxic and their hearts slow down, becoming more bradycardic. Very important point. Now for shock, a condition that develops when the circulatory system is unable to deliver sufficient amount of blood to the organs. This results in organ failure and eventually cardiopulmonary arrest. You have the compensating stage of shock and you have the decompensating stage. Common causes include trauma, injury with blood loss, especially abdominal, dehydration from diarrhea or vomiting, severe infection, neurologic injury such as severe head trauma. Common causes include severe allergic reaction, anaphylaxis to an allergen, right? Insect bite or food allergy, diseases of the heart, collapsed lung, that's a tension pneumothorax, blood or fluid around the heart, cardiac tamponade, both tension pneumothorax and cardiac tamponade, and even pericarditis is a form of obstructive shock. So the pump is being affected indirectly. Pediatric patients respond differently than adult to fluid loss. They may respond by increasing heart rate, increasing respirations, and showing signs of pale blue skin. All right, now signs of shock in children. Tachycardia. You'll see tachycardia, bradycardia, death, right? Poor capillary refill time, good tool to check, good examination to do for your pediatric patients, I should say. Pay attention to their mental status changes. Treat shock by assessing ABCs, intervening as required. The order becomes CAB if there is obvious life-threatening external hemorrhage or if cardiac arrest is suspected. Pediatric patients do not demonstrate a fall in blood pressure until shock is severe. So it's tachycardia, bradycardia, pressure drop, death, right? Shock treatment. In assessing circulation, assess the rate and quality of pulse. The temperature and moisture of the hands and feet, skin color, capillary refill time within 2 seconds is considered normal. Changes in pulse rate, color, skin signs and capillary refill time will suggest shock. Blood pressure is most difficult vital sign to measure, especially in the age group below 3. So rely more on the skin changes or skin circulation changes. Assessment should also include talking with parents or caregivers. Limit your management to simple interventions. Do not waste time performing field procedures. Ensure airways patent. Prepare for artificial ventilation. Control bleeding. Give supplemental oxygen by a mask or blow-by depending on the developmental age group. Continue to monitor airway and breathing, so that's upper and lower airway. Position the pediatric patient in a position of comfort, keep them warm with blankets, maintain body heat, especially for the younger pediatric population. Provide immediate transport, contact ALS for backup as needed. For anaphylaxis, a life-threatening allergic reaction that involves generalized multi-system response. So with anaphylaxis, the airway constricts, the blood vessels open up. This results in the patient not being able to breathe properly, and the vasodilation causes a drop in cardiac output. So there are 2 problems present. It's characterized by airway swelling and dilation of blood vessels. Common cause are insect sting, medications, and food allergy. Signs and symptoms, you're looking for a drop in the blood pressure, stridor, upper airway, wheezing, lower airway, which indicates bronchoconstriction, increased work of breathing, altered appearance, restlessness, agitation, and sometimes a sense of impending doom. Look for the hives. Treatment, maintain airway, administer oxygen, allow caregiver to assist in positioning the patient, oxygen delivery, and maintaining calm. Assist with epinephrine auto-injector based on protocol, and it would be the medial aspect of the leg, not the lateral. And it's half the dose that you would give to an adult patient. Bleeding disorders, hemophilia, congenital condition in which patients lack normal clotting factors. Most forms are hereditary and severe. Predominantly found in the male population, they may occur spontaneously. All injuries become serious because blood does not clot. For your altered mental status, you'll be thinking about your A, E, I, O, U types, right? Alcohol, epilepsy, endocrine electrolytes, insulin issues, opiates and other drugs, uremia, kidney failure, trauma, temperature, infection, right? Poisoning, psychogenic causes, shock, stroke, seizure, syncope, space-occupying lesion, subarachnoid hemorrhaging. For your altered mental status, signs and symptoms will vary from simple to confusion to coma. Management, focus on ABCs and transport. Level of consciousness is low, patient may not be able to protect their airway. Ensure patent airway adequate breathing through non-rebreathing mask or BVM. Transport to the hospital, right? You are able to manage the pediatric patient airway effectively, you will save their lives. All right, now seizures. Results of disorganized electrical activity in the brain. Manifest in a variety of ways, subtle in infants with an abnormal gaze, sucking, and or bicycling motions. More obvious in older children with repetitive muscle contractions and unresponsiveness. I have numerous causes, right? Once seizures stop and muscle relax, it is referred to as a post-ictal state. The longer and more intense the seizures are, the longer it will take for this imbalance to correct itself. The post-ictal state is over once normal level of consciousness is regained. Status epilepticus, these are seizures that continue every few minutes without regaining consciousness in between or last longer than 30 minutes. So this is a patient in which medication may be required to stop the seizure. Now, recurring or prolonged seizures should be considered life-threatening. The patient does not regain consciousness or continuous seize, protect him or her from harming self and call for ALS backup. Management, securing and protecting the airway is your priority. Position the head to open the airway, keep the mouth clear with suctioning. Use recovery position if the patient is vomiting. Provide 100% oxygen by a non-rebreathing mask or blow-by method. Begin BVM ventilations if there is no signs of improvement. All right, seizure management. Some caregivers will have given the child a rectal dose of diazepam, Dista, prior to your arrival. Monitor breathing and level of consciousness carefully. Transport to the appropriate facility. Meningitis. Inflammation of tissue that covers the spinal cord and brain. caused by infection by bacteria, viruses, fungi, or parasites. Left untreated can lead to brain damage or death. Being able to recognize a pediatric patient with meningitis is an important skill to have. So, meningitis, individuals at the greatest risk: males, newborn, infants, patients with compromised immune system from AIDS or cancer, history of brain, spinal cord or back surgery, children who have had head trauma, children with shunts, pins, or other foreign bodies in their brain or spinal cord, especially children with VP shunts. Signs and symptoms vary with age, fever, altered level of consciousness. Changes can range from mild headache to inability to interact appropriately. Child may experience seizures. Infants younger than 2 to 3 months can have apnea, cyanosis, fever, distinct high pitch, or hypothermia. Meningeal irritation or meningeal signs are terms to describe the pain that accompanies the movement, often resulting a characteristic stiff neck. In an infant, increasing irritability and bulging fontanelle without crying. That's what you need to be looking for. This area, meningitis. Well, I can't pronounce that one day. My brain won't allow that today. It is a bacterium that causes rapid onset of meningitis symptoms, often leads to shock and death. Children present with small pinpoint cherry red spots or larger purple-black rash. Serious risk of sepsis and shock and death exists. That's what that looks like. All right, now patients with suspected meningitis should be considered contagious. So always assume that they have the contagious form of meningitis. Use standard precautions, follow up and learn the patient's diagnosis, treatment, provide supplemental oxygen, assist with ventilation if needed, reassess vital signs frequently. Right? Gastrointestinal emergencies and management. Never take a complaint of abdominal pain lightly, right? So don't play around with abdominal pain in your pediatric population. Monitor for signs and symptoms of shock. Complaints of gastrointestinal origin are common in pediatric patients. Ingestion of certain foods or unknown substances. In most cases, patients will be experiencing abdominal discomfort, nausea, vomiting, and diarrhea, and this can lead to dehydration. Appendicitis is also common. If untreated, it can lead to peritonitis or shock. Will typically present with fever and pain upon palpation of the right lower quadrant. Rebound tenderness is very common, right? So that's a common sign of appendicitis. If you suspect appendicitis, promptly transport to the hospital for evaluation. Obtain a thorough history from the primary caregiver, right? How many wet diapers today? How many times has the child had diarrhea and for how long? Are tears present during crying? Is the child tolerating liquids and keeping them down? Right? And this is what poison. All right, so we are going to, let's see how many slides left. Quite a few. 280, that's 140. All right, so we are going to stop here today for this chapter. Right? We will pick up, we will finish the chapter on Thursday. So let me, all right, so what we will do for the next hour is we'll shift the focus more to scenarios. So we'll pick up back on the pediatric Emergencies on Thursday. Excuse me. And remember what I said, it's a long chapter. It's a very long chapter inside of the book. It is a book within the book, right? But right throughout the emergencies that we have covered so far, it has highlighted pediatric considerations, which you should have been paying attention to, right? So really what you're looking for in the chapter is what is different. And more of what I have gone through so far is the same medical conditions, the same pathophysiology, right? The same thing, right? It's just repetition. It's a lot of repetition. But you need to focus on what is different. What is different? What do I need to commit to memory when dealing with a pediatric patient? And what is very consistent in the management for pediatric patient? Airway. That's the most consistent management, Being able to manage their airway effectively, being able to limit the patient from losing body heat based on their size, looking out for signs of dehydration, and infection, right? Providing humidified oxygen if they have respiratory tract issues. But we will continue on Thursday. All right, so let's focus on scenarios. Now, the approach that we will take from this point on will be based on the skills evaluation, right? So we are now going to start with airway. So we're starting with upper airway management, and upper airway management entails proper positioning of the airway using the appropriate airway adjunct and positive pressure and suctioning. So that's where we're going to start today. So for upper airway, you don't get more than 5 minutes for that skill station. Won't get more than 5 minutes. So this is a scenario. You have a patient that is found at home, in bed, not responding. Adult patient found at home, found in bed, the patient is not responding. That's the information you have received from dispatch. You are required to demonstrate how you would manage the upper airway for this patient, upper and lower, I would say, for this patient. So you're not required to complete a full assessment. You're required to just manage the upper airway of the patient. And before I go into that, let me just show you what it is that I am looking for. Where are my videos? All right, this is what I'm looking for. Okay. All right, this is what I'm looking for. All right, so let me share my screen and we'll look at this video. Share application. All right. All right, everybody can see the video on the screen. Everybody
Yes, sir.
seeing the video? All right.
Yes, sir.
All right, so the scenario is a patient that is unresponsive and apneic. Apneic means not breathing. So pay attention. Everything that is being done is what will be expected. So you're not doing a full assessment. All right. So let me back up a bit. Let me back up a bit. Oh, the wrong thing.
Sir, I'm not able to see the video. It says my connection can't display it, sir.
That's a problem on your end. That wouldn't be a problem on my end.
There's audio, sir. I'm not hearing.
Hold on, let me close this and open it with a different, where is it? Let me see if I can open it with something else. Let me try this one. Still low. So the audio is still low. All right. All right, so I'm gonna have to work on that audio. Now, the question I'm gonna ask is, because this is the same airway demonstration that is found in the airway management module on the platform. How many persons have reviewed that video? I see Nesbeth, I see Rowan. Okay, so that's Nesbeth, Miss Nesbeth, Rowan, and Mr. Jennings. What about the others? So, Miss Dennis, why have you not reviewed the video? What's the reason for that?
I didn't hear what you said.
I'm saying if you have I'm hearing feedback.
I don't know what's happening.
I was saying to you that if you review the airway management demonstration on the platform.
Yes, sir.
Okay. All right, so that's Miss Dennis. Miss Johnson, have you reviewed that video?
I'm trying to remember if I did, sir. I've watched so many videos, sir. But I think so.
Miss Jackson. Miss Jackson?
I had seen that video, sir.
All right, so based on the responses I've heard, everybody has reviewed the video. Okay. So as I said, you're required to manage the upper airway and the lower airway. Right? It's a patient that is found unresponsive, no ventilations, with a pulse that is below 60. You will start with your level of consciousness. So you check the patient's level of consciousness. Sir, can you hear me? Patient doesn't respond to your voice, you apply painful stimuli. Patient doesn't respond to pain, the patient is unresponsive. There is no spinal injury, so you perform a head tilt, chin lift, make sure the airway is clear. You will look, listen, and feel, and simultaneously check the pulse, right? There is no chest rise, there is a pulse present. You want the rate, the rhythm, and strength of that pulse. The pulse is slow, it is regular, it is weak, and it's the carotid. At this point, you have established that the patient requires upper airway management and lower airway management. So you decide on the most appropriate airway adjunct. Based on the presentation, you will start with your OPA. You get your OPA, you measure the OPA, you insert the OPA, and you start to breathe for the patient with a BVM and an oxygen source attached. You give one breath every 5 to 6 seconds. For this patient, the fact that the patient is not breathing, after 2 minutes, you have to check that the pulse is present. If you're providing positive pressure with a OPA insert and the patient starts to gag, if there's no spinal injury, turn the head, pull the airway adjunct out, get ready to suction. If it's a large amount of secretion, rigid catheter. Minimal secretions, flexible catheter. You turn on your machine, measure your suction device, check your suction pressure, at least 300 millimeters of mercury, test your suction, insert into the liquid, seal, create suction, suction side to side or in a circular motion out. Once you have cleared the airway, you repeat your level of consciousness. Something has changed. Go back to the beginning. Sir, can you hear me? No response. Check in, patient groans. Still position the airway. Make sure it's clear. Look, listen, feel. Check for a pulse. There is no breathing. The fact that there is breathing, you will evaluate the breathing. Check the rate, rhythm, quality, and depth. Is it too fast or slow? Is it consistent? Is there muscle use? Is there abnormal sound? What is the pulse ox? Breathing. Patient is breathing slow at this point, poor chest rise. So it means that an airway adjunct is indicated. The airway adjunct of choice at this point, because the gag reflex is present, is the NPA. You take up the device, measure it from the tip of the nose to the earlobe, lubricate, insert in your right nostril. That would be the end of the scenario. So that is all that is expected. All right. Yes. Go ahead.
Afternoon, sir. So just to provide some assistance when displaying the video, it say that you should, when you select the share screen, you would click on the share audio checkbox. And once you check that, then it should allow the audio to come through as well. I'm gonna send you this link.
I don't think that is the issue. The issue is the video itself. So something is wrong with the audio and the video. That's the problem. Right, but I'll work on it. All right. Miss Johnson, you're up. 5 minutes. So I won't give you more than 5 minutes. Right? So you have a patient that is found not responding, not breathing. You have 5 minutes to walk me through your assessment and management of the upper airway. Go ahead.
Hello, sir. Can you hear me?
You don't get any response.
Okay. I'm going to use the painful stimuli.
Doesn't respond to pain.
Okay, so this person is unconscious.
Mm-hmm.
So I am going to, is the person responsive? I mean, breathing?
How would you determine that?
Chest rise, sir. There's no chest rise. So I'm going to open the airway using
Okay.
the, because I don't suspect any spinal injury.
No
So I'm
spinal
going to
injury.
use a jaw thrust chin lift to open the
Head
airway.
tilt chin lift. Head tilt chin
Head
lift.
head tilt chin lift. So I'm going to open the airway and I'm going
Mm-hmm.
to check to see if there is any obstruction,
No
maybe
obstruction.
dentures or mucus vomitus. Okay. So I'm going to what am I going to do? Okay, so the airway is patent. So since there is no chest rise, then I am going to check the pulse. No. Since
There
there's
is a
no chest
pulse.
rise,
There is
okay,
a
there's a pulse.
pulse.
Okay, so I'm going to help the person to breathe since there's no chest rise.
There is
So
a
I'm going to
pulse.
use a,
Hold on. There is a pulse. What do you assess in the pulse?
I am going to assess the, I'm going to see if it is in the range, which is 60 to 100 beats a minute. I'm going to see if it is bounding, thready, or irregular or regular.
Okay. Patient has a pulse rate of 40 beats per minute, regular weak. No chest rise, unresponsive. Management.
So BVM, since there's no chest rise, I'm going to administer it with oxygen, since
You're only using a BVM, ma'am? The
pardon
patient
me?
is unresponsive. Are you only going to use a BVM, an oxygen? The patient is unresponsive.
Oh, sorry. I'm going to use an ORA, sir.
OPA.
Insert a, oh, God have mercy. OPA, and then once that is inserted, then I'm going to
How do
attach
you
the.
measure the OPA before insertion?
So I'm going to measure it from the tip of the mouth to the front of the ear.
In what position?
In the position that it is supposed to be inserted, which is the curve is down.
Okay, you insert your OPA, you're bagging your patient. What is the rate that you ventilate this patient at? Quickly.
So it's one every 5 to 6 seconds.
Patient start to gag on the airway device. What would you do at this point?
Turn the patient, since the patient don't have any spinal injury, turn the patient head to the side and
Mm-hmm.
then suction the airway because the patient
You're
probably
gonna
have mucus or
you're gonna suction with the device in the patient's mouth.
no. I'm going to remove it, sir,
Okay.
and then
The
suction.
patient has a large amount of secretion. Which airway which suction catheter would you use? Rigid or flexible?
Rigid, sir.
What is the
And then I'm going
suction
to
pressure required?
300. I don't remember what
Do
is
you
300
suction
some.
300 millimeters of mercury? Do you suction
Okay.
going in or suction going out?
Suction going out in a side-to-side motion or circular motion, sir.
Okay. After you have finished suctioning the patient, what would you do at this point?
Then I am going to check to see the rate, rhythm, and
Can
I
do
need to
that
tell you what.
first. You have to check the patient's level of consciousness. Yes?
True.
Good.
So check the patient level of consciousness once again.
Patient is responding to pain. What would you check after that?
Then I'm going to check the breathing to
How
see
would you
if
check breathing? How would you check
so
breathing?
so I will check the rate, which is see whether or not the person is breathing within the limits, which is
What do you
12 to
need
20 breaths per minute.
What do you need to position before checking breathing?
What do I need? Oh, reposition the head, sir, and put it back into the
Good. So you open the
jacket.
airway. Open the airway, right? Patient is now breathing. What are you checking in breathing?
So I'm checking to
All
the
right,
rate.
that's it. That's it. That's your 5 minutes,
Okay.
right? So if you were being evaluated, you would not have completed the scenario within the 5 minutes. So you're still using too much time to think about things that you need to do. So you're going over your 5 minutes, right? You're thinking too much. All right, so that was Miss Johnson. Miss Dennis, your time. Same scenario. Same scenario. Patient found at home, not responding. Go when you're ready. 5 minutes.
Okay. Sir, I tap the patient on the shoulder. Can you hear me?
No response.
Okay, apply painful press on
Hold
the.
on, Miss Dennis. Do you have the platform open on your phone?
Yes, sir.
Log out. Are you using your computer as well?
No, I having network problems.
I keep hearing feedback, so something is wrong. So hold off for today, because I can't manage the feedback.
Okay.
All right? Mm-hmm. All right. Rowan, go. 5 minutes. Patient found at home. Not responding. No breathing. Go.
Hello, sir.
No response.
Looking for painful stimuli.
Doesn't respond to pain.
Okay. All right. At this time, I'm going to use. Do the head tilt chin lift.
Okay.
Position in the area to find out if the area is patent.
It's clear.
Area is clear. Area is clear. Area is clear. Checking for breathing, sir.
There's no signs of breathing. Can't see any breathing.
Can't see any breathing. What about chest rise?
There is no sign of breathing.
Okay. All right.
Okay.
At this time, I'm going to use oral airway.
You know if your patient have a pulse, young man?
Oh, sorry. Yeah. I'm gonna check the pulse, sir.
Pulse present.
Pulse is present. All right. So I'm gonna check the area this time, sir.
What do you evaluate in the pulse?
So I'm gonna evaluate the rate, the quality, and the rhythm.
The rate, quality, and what?
Rhythm, sir. Pulse rhythm.
What do you mean by rate?
So you see the patient is breathing within 100 beats per minute or 60.
We're talking about a pulse. We're not talking about breathing. Concentrate. What are we checking in the pulse?
Sir, we're checking if the pulse is weak or 30, sir, or if it's irregular.
That's rate.
Uh-huh.
I asked you about rate.
Yes, sir.
What do you check in the rate, young man?
Sir, the patient should have a pulse of 60 to 100 beats.
And what if it's outside of that? I don't understand what you're saying, young man. What are we checking in the rate?
So we're checking for the rate, sir. If it's less than 60, sir, or if it's 100 beats per minute, sir.
All right. So I'm going to pause there for your scenario. All right. So this is what I'm getting from you, Rowan. You're not demonstrating understanding. I'm asking you a simple question and you're getting flustered. It's a simple question I'm asking. What are you checking in rate? You're checking if it's fast, slow, or normal. That's it. I'm not getting that from your response. So there's an understanding issue. So if you were being evaluated, I would stop you and fail you at this point. All right? because there's an understanding problem. All right, Jennings, go, same scenario.
All right, sir. Firstly, I want to take standard precautions. Putting on gloves. Is my scene safe?
Yes, it is.
All right, I'm approaching my patient. My patient appears to be unconscious. I'm tapping on his shoulders and I'm calling him, sir, sir, can you hear me? Am I
No
getting any
response.
response?
No
Good.
response.
I'm assessing for pain using a supraorbital nerve. Is he
No,
responding to pain?
no response to pain.
My patient will then be called unresponsive. I'm going to position the airway. Is there any breathing going on? Am I feeling anything? I'm opening his airway. His airway is open using the head, tilt, chin lift.
Okay, there's no signs of chest rise. No breathing.
Sorry, backtrack. I want to consider spinal. Is there any signs of spinal injury?
No spinal injury.
Okay, good. So yeah, so we're moving on to head, tilt, chin lift. You said that there's no activity. We're moving on to breathing. Is there any chest movement?
Nope. No breathing.
Does my patient has a pulse?
Yes, there is a pulse.
Is the pulse fast or slow?
How would you ascertain that?
I want to palpate the carotid artery since my patient is unresponsive.
Okay. How would you check the rate?
You want to count for at least 30 seconds the number of beats and then multiply that by 2.
Okay. Patient has a pulse rate of 40 beats per minute. What else are you checking in the pulse?
Is the pulse regular or irregular?
It is regular.
Is the pulse weak or strong?
Weak.
At this point, I would move on to try and correct the breathing situation. So first, I want to use a OPA, an oropharyngeal airway. I will measure the opening of the mouth to the jaw of the mandible, so that's anterior to the ear. So I'm placing the flange of the OPA at the corner of the mouth, and I'm placing the hollow opening at the jaw. That's how I would measure that. I'm inserting my OPA by turning the curve downwards and then rotating 180 degrees to scoop the tongue out of the airway as I'm placing it inside. Am I noticing any gag reflex?
Airway adjunct is in. You need to bag the patient. What's your ventilation rate? Quickly.
I'm ventilating at 1 breath every 6 seconds.
One breath every 5 to 6 seconds.
5 to
The
6
patient's
seconds.
about
Okay.
to get on the device. What would you do at this point? Quickly.
I'm removing the airway and I'm checking for any
Are you going to
debris.
remove the airway or turn the patient head to the side? Which is it?
You would turn the patient head to the side to see if there's any vomitus coming out and then remove the airway.
Okay. Remove the airway adjunct. The patient has a large amount of secretions coming out of the mouth. What would be a management? Quickly.
I would want to suction the airway, so I'm preparing the suction device. I'm preparing the suction at 300 milliliters of mercury. Is the vomitus like chunky or is it just fluid?
Fluid.
Okay, I would want to use a flexible catheter since it's fluid. I would then check the suction against my glove to ensure that it is suctioning, and then I would measure by placing the tip of the catheter at the same place, the jaw of the mandible, and then at the corner of the airway, I would place my finger as a measurement. I would then place it inside, and I would begin to suction in a circular motion coming out of the airway.
Okay.
Is the airway clear?
Clear the airway. What's next?
After clearing the airway, I would want to reassess my patient. So I'm going back because obviously he started to gag. I'm going back again, checking. Sir, can you hear me? Is he responding to verbal stimuli?
Patient responding to pain.
Okay, my patient is responding to pain. Next, I want to open the airway. I'm opening the airway. Is there any noticeable difference? Is there breathing? Am I feeling anything?
Slow breathing. Breathing rate is slow, poor chest rise.
Okay, at this point, my patient is still having some considerable challenges with breathing. I would want to now insert an NPA. I would then take the
5 minutes.
NPA.
5 minutes, that's it. That's it. 5 minutes. So you would have gone over your limit, right? So you need to learn to get to the point, young man. You need to get to the point, right? There are certain things that you don't need to go into too much detail about. And when I'm testing students practically, if you let your 5 minutes run out and you have not completed the scenario, I can't pass you. So if I don't see what you're doing practically, I can't grade it. So there are certain things you don't need to explain, right? So the patient, you're going to assess the patient for verbal stimuli. The patient doesn't respond, you apply pain. Doesn't respond to pain, the patient is unresponsive. At this point, position the airway, look, listen, and feel. Can I see chest rise? Is there a pulse? No chest rise, there is a pulse. I want to determine at this point, is a pulse fast, slow, or normal? I will give you the feedback. Based on that, okay, patient requires a OPA. I'm going to measure from the corner of the mouth to the earlobe, insert towards the hard palate, rotate 180. Once airway is in place, I'm going to bag this patient using a BVM, 1 breath every 5 to 6 seconds, with oxygen attached at 15 liters per minute, 1 breath every 5 to 6 seconds. Patient start to gag. I'm going to turn the head to the side, pull the airway adjunct out, examine to see what type of fluid coming out of the mouth. It's large secretion, rigid catheter, minimal, flexible. Turn on my machine, check it, get it to the required suction pressure, 300 millimeters of mercury. Measure, insert, suction while coming out, 15 seconds for adult, 10 for a child, 5 for an infant. Once cleared, reassess the airway. Reassess level of consciousness. I will give you information based on what you said to me. Patient is semi-conscious, position the airway again, look, listen, and feel, check for a pulse. Am I seeing breathing? Breathing is present. At this point, is it fast, slow? Is it regular? Is there muscle use? Is there abnormal sound? I will give you the findings. So you need to cut out the extra information that you're giving, else you're gonna lose important time, right? So you almost made it to the 5 minutes, almost. So you're at the point where you decided to go with your NPA. So all was left for you to do is explain how you would measure and insert it. If you had gotten to that point, then definitely you would have made it. All right, but you're on the right path. You're on the right path. Right?
Oh,
so
I never tell you how to measure it. Sorry.
right? So you're doing what you're you're saying, I should say, what you need to say. There's a sequence, you're following your sequence, you're doing okay. Just focus on what is needed, right? Don't give me all of that extra information. Not right now. Give me that when you're doing your exam, your written paper. All right. Miss Nesbitt, your turn. Go for it.
Take standard precaution using a pair of gloves. Level of consciousness. Sir, am I getting a response?
No.
Painful stimulus. Am I getting a response?
Pain. Doesn't respond to pain.
All right. Doing the airways, no. Patient is unresponsive doing the airways. Opening the airway using the head, tail, chin lift measure. Simultaneously assessing breathing and circulation by looking, listening, and feeling. Am I seeing chest rise?
No chest rise, there is no pulse.
Okay. How is the pulse? Is it slow, irregular, regular, normal, fast?
Patient has a pulse rate below 60. It is regular. It is weak.
Patient needs assistance with positive ventilation, using an OPA, measuring the OPA using from the tip of the lips to the edge of the lips to the tip of the earlobes. positioning the in the position of function, inserting the airway, turning it to 180 degrees, providing BVM using 15 liters of oxygen, 100% oxygen, and giving 1 breath every 5 to 6 seconds. Squeeze, 2, 3, 4, 5, squeeze.
Patient gagging on the airway adjunct. Patient gagging.
I'm removing the airway adjunct, positioning the patient to the side, getting my suction.
Hold.
Moving the patient as a unit.
Are you going to remove the device first or turn the patient? Are you going to pull the airway adjunct out first or turn the patient? Which is it?
I'm going to pull out the airway adjunct.
So when you pull out the airway adjunct and his head is neutral, where's the vomitus going to end up?
Oh, I'm sorry. I'm going to position the patient's head to the side, pull out the airway adjunct, then I use the suction, get the machine ready at pinching the tubing until it reaches 300 millimeters of mercury for the pressure. I see how much vomitus I'm going to use. Is it large or small?
Large amount of secretion.
Using a rigid French tip catheter, going into the
large amount of secretion.
Rigid catheter.
Okay.
Sorry. Going into the mouth, I'm moving from side to side, coming out in a circular motion. Suctioning for 15 seconds since it's an adult.
You clear the airway. The airway is clear. Airway is clear.
All right, so I'm going to be reevaluating now since the patient now has a gag reflex. Sir, still no verbal stimulus response?
No response.
Is the patient doing painful stimulus, responsive to painful stimulus?
Patient responds to pain.
Positioning the airway again with the head lift, tilt, chin lift. And now because the patient has a gag reflex, I'm going to be using the NPA.
Hold on. You position the airway. What do you
I'm positioning the airway. And then I'm going to check again for breathing. So I'm going to simultaneously do the breathing and circulation. I'm feeling the cardiac pulse. What's happening?
The patient is now breathing. The breathing is slow. There is poor chest rise.
Still needs positive ventilation. Going to be using the MPA now. So I'm going to be getting it, measuring it again, using the same method from the tip of the lips, the earlobe. You insert it, lubricating it, inserting it into the right nostril with the bevel pointing towards the septum and starting positive. Using the BVM again with oxygen 15 liters per minute, 100% oxygen.
How are you going to breathe for this patient that is breathing? He's breathing slow, but he needs positive pressure. How do you ventilate this patient?
So because he is now breathing for the first 5 to 10 breaths, I'm going to be going with his breathing, his pattern of breathing, and then I'm going to then put it to 1 breath every 5, one breath every 5 to 6 seconds. After.
Okay. All right. That's it. So that's 4 minutes and 48 seconds. All right. Miss Dennis, how are you staying now? Miss Dennis?
Hear me better now, sir?
All right. I'm no longer hearing feedback. No, I'm hearing feedback.
You're hearing feedback?
Yes, I can still hear.
I even moved from where I was.
It's okay. We will do this again. But something is causing feedback on here, and I don't know how to do it. All right. So let me mute that mic. Oops. Think I removed her by accident. Oh my God. Anyway, I was supposed to mute her mic, but I ended up removing her. Miss Jackson.
Yes, sir.
It's your turn. Go ahead.
So we're going to consider the scene safe.
Hold on. Let me set up my clock. All right, go ahead now. Yes, the scene is safe.
We're going to take basic precautions. We're going to wear a pair of gloves. We're going to check the patient's level of consciousness. We're going to tap the patient on the shoulder. Sir, are you hearing me?
No response.
We're going to check the patient's pulse. Is there a pulse?
The patient didn't respond to pain. What do you need to do at this point?
Oh, check breathing.
How are you going to do that?
Look for chest rise and fall.
What do you need to do before you look for chest rise and fall?
Check the airway, sir.
Okay. How would you position the airway? What method I should ask would you use to position the airway?
Head tilt, chin lift.
All right, so you're going to simultaneously position the airway using the head tilt chin lift. As soon as you position the airway, put your fingers on that pulse.
The cardiopulmonary pulse.
Why am I hearing feedback?
Hearing
All
me,
right.
sir?
Yes, but I'm hearing feedback. Yes, so there is a pulse. The patient is not breathing.
Okay, so we're going to. There's no sign of spinal injury, so you're going to position the airway using the head to chin lift and place an OPA in the airway.
You're going to do what?
Going to insert an OPA. Hearing me, sir?
All right. Give me a second. I think I'm having some issues on my end. Let me just